So one of the things as we move on, I've done one video already of medication administration, and now I'm doing something that's kind of pharmacology medication administration, because that is something you just really have to get a grasp on in the beginning of your nursing, because that is something we're going to do forever, is give medicines as nurses. That is what we do, and we want to do it safely and protect our patients and clients, and also protect ourselves and our licenses that we work so hard to get. So let's get started. Medication administration pharmacology. So a quick overview, a drug is any chemical that affects the physiological processes of a living organism. So if it affects our physiological processes of any form, it's considered a drug. We have drugs that are over the counter, we have prescription medications, and then we also have holistic medicines out there that really do impact our bodies. So it's something to think about, but that is what a drug is. And pharmacology is the study or science of drugs. It encompasses a variety of principles, and that's kind of the overview of what a drug in pharmacology is. So I previously just did a video on how to make a drug card, and so I talked a little bit about a generic name and a trade name, and you just need to understand that on the for the board of nursing to take your actual NCLEX, they use generic names for their drugs, so you need to be learning that generic name. Now, when you start to whip out generic names to patients or clients, they're going to go, and you're going to have to say Tylenol or whatever companies, Dimetapp back in the day, they've taken that off the market now. But anyway, so if you look at this, a chemical name describes the drug's chemical composition and molecular structure. So I used Tylenol as my example. I highlighted them here in yellow. So as you see, it's N-acetylCP, aminophenol. I can't even say it. Don't make fun of me. But that is a chemical name. Do we say that when we want a couple Tylenol? No, we don't. Acetaminophen is the word or the term or the name. It's the generic name of Tylenol, and it is what you will see on your boards. It is how you should refer to it. But there are people out there that you have to say, you need to use baby Tylenol, or you need to use, Tylenol. So, but that is the generic name. It's a non-proprietary name because, and it's given by the United States Adopted Names Council. So that's where it goes. The trade name is the proprietary name. And this is where the companies, this is the registered trademark, Tylenol. Use of the name is restricted by the drug's patent owner. So the manufacturer usually owns the patent to make the drug, and they own that name. So what happens is drugs are formed, we get them out there, and at least back a few years ago, this is how it worked. It might work faster now, but I'm not sure. But usually they'll have a patent, and for so many years, it could be 7 years, 3 years, 5 years, whatever the patent says, they're the only ones who can manufacture this drug. No one can come up and go, I'm going to add a little something and make it this, but it's the same chemical name, where it's the same compound. You're not allowed to do it. So you need to know your generic name. Trade name is what it is, so you understand that when you see it, and then the chemical name. And you don't normally see the chemical names unless you truly are in the pharmacology piece or in a lot of the medical school piece. So, but for nurses, we need to know generic name and trade names. And when you make your drug cards, make sure you have those on there. So we have drug classifications, and this is where the drugs are grouped together based on the similar properties. It could be based on their structure, like they're made with this, and this is what they do. They have subclasses. As you can see, it says subclass, selective, non-selective. When you're reading your drug, you're going to see these things and understand this is what it's saying to you. So more or less what it is it's piling medications up under certain things. So like an antibiotic. Well, we'll have antibiotic as a big broad. All the antibiotics are up under an antibiotic, but we have different ones. So we have subclasses of medications. So, you can have cephalosporins, you can have this kind of antibiotic, that kind of antibiotic. And so that's what we're seeing, and that's what they're saying. So lots of times you'll start to say the first drug in a class of drugs. So when we start to talk that, we're talking about the beginning. So the actual type 2 diabetic medications that are out, the Ozempics and all of that. Metformin is one of the first drugs that were made. It's their first. And so they did that, and then they've expounded upon that, and they have this and this, and we get to Ozempics, we get to this, and we keep seeing them coming out different. That's classifications of drugs. But if we were going to put them under a broad, right, band of where all those drugs go, they would go up under the type 2 diabetic medications to control that. I hope that makes sense, but I just want you to get a brief kind of understanding of that with classification. Now, the other thing that you will see are scheduling of drugs. It's called the definitions of schedules. We have 1 through 5, sometimes 1 through 6. Here is an actual table that I'm just sharing with you, and it tells you, so if it's a Schedule 1 drug, it's a high potential for abuse. There's no currently accepted medical use in the U.S., lack of accepted safety for the use of this drug for medical supervision. So Schedule 1 drugs are things that we see that we're not giving. Doctors are not prescribing these drugs. These are things that we could see out on the streets or in other countries or wherever, but they're Schedule 1. Schedule 2's highly potential for abuse. You can read through them. I'm not going to read it all. Schedule 3's potential for abuse is less than the 1s and 2s. They are accepted for medical use in the U.S. Abuse may lead to be a moderate or low physical dependence upon the drug. So we are going to set, so do you have a Schedule 1, 2, 3 drug? Schedule 4, lower potential. If you notice, as we get higher in the number, the lower the potential. Do you need to memorize this? No. For my students, for testing purposes this week, no, you don't need to memorize this, but you need to understand when you're making your drug card and you're using narcotics, if you have a narcotic or you have something that is a scheduled drug, you need to understand if it says Schedule 1, what does that mean? So that when you're in the clinical setting and you're asked, you can say it's a high potential for abuse. We're not even allowed to give it in the U.S. It's not given in the U.S. It's a Schedule 4, Schedule 5. So, and when you're making that and getting that information for giving medications, you understand when it says that. You need to know, is it a Schedule 3? Because we need to understand if we're giving something every day to a patient or a client that's going to make them an addict or addicted to this drug. It's very, very important. So pharmacologic principles are out there, and there's some that you need to understand and know, and some parts of these that you really need to know. But I just want to give you a brief little kind of snippet. And there's also others out there, but we don't need to go right now at the very beginning of this that in depth. But we have pharmaceutics, and I will define that here in just a minute. Pharmacokinetics, that's a very important one for us. Pharmacodynamics, pharmacotherapeutics, and toxicology. So we're going to cover these really quickly. And don't get so bogged down like, oh my gosh, there's so many terms. You do need to understand some of these, and I will definitely point you in that direction. But these are something to look at, look up, read into, because this is a part of pharmacology. So when we're looking at the definition of pharmaceutics, I don't need you to memorize this. I'm familiarizing you with this so that you understand. Each piece is going to look at a different part of how a drug or what a drug does to the body. And it's important to know this, especially if we are helping with education on medicines or even giving medicines. So if something's going on in the clinical setting, you're fearful or you're wondering, should I be giving this medicine based on something going on with the disease process? We need to understand a little bit so that we can make good critical thinking judgments of what we're going to do with the medication administration that we're doing. Be safe, practice, no harm to your patient. That's what we want. Now, pharmacokinetics is a big one, and I do want you to kind of really read through that. Go back through if you are in your book, whatever book you're using. It's in any nursing book. If we're looking at the beginning of medication administration, you'll see it. But with pharmacokinetics, it is the study of what the body does to the drug. So absorption, distribution, metabolism, and excretion. So we get it in, we distribute it however it's supposed to go, we metabolize it, and whatever we don't need or whatever, then we excrete it. And usually with our liver and our kidneys is how we excrete medicines or break things down. So that's something to look at. So this slide to me is a little bit better with the definition. So pharmacokinetics is the study of what I just said. It's on that slide prior, but it breaks this down a little bit more. The dissolution of medication is dependent upon the initial state and the route of the administration. More or less, this is saying is, how is this going to go into the body? It depends on the rate, how it breaks down and what it does, on where and how we give it. And we'll go over all the routes that we can give medications. But if I give something IV, if I am putting it directly into that vein, it is the fastest way to administer any medication. Is it because we're putting it directly into the bloodstream that's going to circulate immediately through the entire body, going through the heart, through the brain, all of that. It is in that. It's the quickest stage. If we give it through the GI tract, which is where we take a pill and swallow it, or if we go through an absorption piece where we put topical things on, that is a slower route than a rate of absorption. And that is what we're looking at when it comes to pharmacokinetics, because if I need to give something immediately and I want an immediate response, I'm not going to slap a patch on their hiney. I'm going to give it to them IV if it's in an IV form and I can, if that makes sense. But if you come down to this next bullet point, most medications are administered by oral enteral route, which provides a much slower rate of absorption. So the other thing you have to think about with this is if I'm giving something really quickly to get a quick reaction, usually those things will be quickly to be excreted through the system or out of the system. But if I give something that is a slow absorption, if you think about it, it's like something slowly absorbing. It takes a while to work it and then it has to process through and put out. It's a slower absorption, so you can get better coverage or longer coverage of a medication based on how we give it. And then distribution is the process of the drug delivery to the target organ or tissues that occur before metabolism or excretion occur. So distribution is in there. So this is how we get it. You get it in, we get it to where it needs to go. We target the area. If it's supposed to target the hypothalamus, if it goes there, before we metabolize it, which is starting of the breakdown of it, and then getting rid of all the byproduct and excreting it out. I hope that makes sense. It's kind of a toughie, but don't make it tough. Just think very simple terms. This is what we do. We get it in. We need to haul it to where it goes. It's going to do its thing. In the process, once it gets there, it starts to metabolize and break itself down and work, because it doesn't stay in our body forever. And then once it is broken down, we need to haul it out and get rid of it, right? We excrete it. It needs to go through the kidneys or however it's going to break down, and we need to get rid of it, or it'll become toxic. So one of the things you see with pharmacokinetics, I just said it, is that it starts to metabolize. So we're going to look at a half-life. The half-life is the time required for 50% of a drug given to be removed from the body. Now this is important to know, and I do want you to understand what a half-life is, because when we start to give insulins and stuff, it's important to know onset, when it peaks, you know, those things. If I'm giving a medication and I need to know when 50% of that medication is out of the body, if it's going to be out within 2 hours, then I know I need to prescribe or give that medicine at this time frame. If it's going to linger for 10 hours, then I don't necessarily need to be piling another narcotic on top of that, do I? Because what I can do is get my patient into a lot of trouble down the road. So we have to be very, very careful. But half-life is the time required for 50 or 50% of a given drug to be removed from the body. That's excretion. So measure the rate at which the drug is eliminated from the body. This measures. That's what we're looking for. But this is kind of an interesting thing, and I left it in. After approximately 5 half-lives, most drugs are considered to be effectively removed from the body. So once you do, say it's 2 hours is the half-life, 5 times 2 is 10, so within 10 hours the drug should be out of the system. So we're able to kind of understand that. And when you're reading that in your drug book, if you've given a medication, you're like, especially if they have a little reaction to it or something, and you don't have anything to give to counter it, you can just say, I'm going to be watching them, watching their vital signs, all of this, but I'm looking to see. I know it says the half-life in 4 hours, so I just gave it. So in 4 hours from now, at least half of it will be out of their system, and hopefully they'll be getting better. So it's definitely something to understand and know. Now, I won't lie to you. For a long time, I nursed in the very beginning when I just got out of school. And they go, well, what's the peak or the trough? And I'd always get that kind of confused. So the other thing is how the drug affects. Pharmacokinetics is we look at how the drug affects. The length of time until the onset of a peak of action and the duration of action play an important part in determining the peak level. And the peak level, put this in your notes, is the highest blood level. So when I say to you, when should it peak? It's the highest blood level. And when is the trough level? And I was always thinking, well, what's that? It's the lowest blood level. So think about it. What's a trough? A trough is usually something kind of low or down. You think of pigs eating out of a trough, that kind of stuff. I always think of that, like a pig eating out of a trough. It kind of triggers me to think it's down low, right? Even though I love pigs, by the way. But that is the highest level and the lowest level, your peak and your trough. If a peak blood level is too high, then the drug toxicity may occur. So what we always want to do, if we have a drug that can be cause toxicity to the body, a lot of times doctors will order a peak and a trough because they're wanting to see. So we're going to usually draw at certain times these blood levels, and then we look. So if we draw a peak and we're way off what it should be, then we're not going to we're going to hold the drug, right? But let's say we do a peak and it's lower than what it should be. We're not where it should be, then they might increase the drug, if that makes sense. And then the trough is also looking at a lowest blood level. So when we're looking at the trough, it should be down at a certain level. If it's too high in that trough, we also need to think about, is the drug causing toxicity or not? Because they're not excreting. What is our excretion? What's happening? So don't get too bogged down with this. Just know what a peak level is and what a trough level is. In time, you'll learn those drugs that we check those, and we'll talk about it even further, I promise. But get those definitions down so that you understand. If someone asks you what a peak level is, you can say that's the highest level of the medication in the blood at that time, of the drug itself. It's the highest blood level of the drug. And same with the trough, lowest. So one more time, because I want you to understand it. So the peak level is the highest blood level of the drug, trough level is the lowest blood level of the drug. Toxicity occurs if the peak blood level of the drug is too high. So we're really looking at peaks, right, more than troughs. Trough is going to explain to us their excretion. Can they get rid of it? Because the trough is the lowest. So we've metabolized it and we're hopefully excreting it. And so that's what we're looking at when it comes to trough. But this is called therapeutic drug monitoring, and this is what we're going to do. So we want to make sure we're where it is. If we're giving enough, not enough, we have to look at those things, and it's so very important. As nurses, we need to know those drugs, and when we see that, understand, and then also to obtain those blood lab levels at the right time. So if you understand we're really needing to know what that peak is, you're not going to be 2 hours late getting a peak lab. You're going to be on it, or you're going to be on the lab to get it for you so that you can get an accurate picture of what's happening with a patient that's taking medications. So the definition of pharmacodynamics, I just want to give it to you, is the study of what the drug does to the body. So we know that the drugs can be renal toxic, liver toxic. So it's what is this drug doing to the body? It's also what it's doing, is it stimulating this or doing that? So that's just a quick little definition of pharmacodynamics. You don't have to memorize it, but just kind of understand it's what the drug does to the body. Simple as that. So the definition of pharmacotherapeutics is the clinical use of drugs to prevent and treat the diseases. So this is where we're looking at either prevention or treatment of what's going on, the disease process. It defines principles of drug actions, the cellular processes that change the response to the presence of the drug molecules, Don't get bogged down with that, big words, big terms. Pretty much, it's just looking at what the drug, the clinical use of the drug to prevent or treat the diseases. And drugs are organized into pharmacologic classes through pharmacotherapeutics. So remember how I said all antibiotics in those classes? So that's what we're looking at. And what do antibiotics do? They fight infection, right? So that's what it's looking at. How is it treating it? It's going to fight infection. And then we go into the subclasses where if it's going to do it this way, if it's going to do it that way. So don't get real bogged down, but just understand that when we're looking at pharmacotherapeutics, this definition, second one, I just have to put that out of my mind because that's just difficult for me. It's a lot of big words, drug molecules, all that. Let's just get down to the layman. The layman is how did the drugs, what the clinical use of the drugs to prevent and treat the diseases, and just remember our classes and how we look at that. We're trying to get a fever down, we're going to use an antipyretic. If we're trying to treat an infection, we're going to use an antibiotic. And then we'll start to break down according to which ones we need for what's going on, and we'll treat specifically at a cellular level to do what it needs to do. So definition of toxicology, science of the adverse effects of chemicals on living organisms. Remember, well, as we go down, I say remember, I haven't even taught it to you, but as we go down, I'm going to talk about adverse effects and side effects. And we really talked about them a little bit when we're making drug cards. There were definitions. So just so you know, remember, if it's an adverse effect, it's an unexpected outcome, something we didn't expect. So this toxicology, we're looking at that. If the patient becomes toxic and something happens, or they're toxic and nothing happens, but they're still toxic on the drug, we need to understand that. And so this is the science for adverse effects when all of a sudden something happens. Clinical toxicology deals specifically with the care of poisoned patients. So we do have toxicology come in if things happen. And it is something just to understand what toxicology is. It's just a definition of the study of. Now, I've said all that. It is major. You do need to understand just briefly what those things, I don't want you to bog yourself down. It's not something to memorize. Notice how I say it's kind of like where we're looking at this and that. Try to start to put things that way as you're studying, because if not, if you try to memorize stuff and just dump it, you're not going to be able to take the test the next time and you see that information, or you're in the clinical setting and see it. You're not going to be able to pull it out. So try to kind of put it however you need to learn it and make it easy for yourself. Don't make it difficult. Look at layman's terms and stuff, but do know you have to learn medical terminology and you will have to be able to read questions. But for right now, when you're trying to grasp things, make it simple as possible. So the next thing we're going to look at is enteral route. That's the drug is absorbed into the systemic circulation through an oral, taking it by mouth, or gastric mucosa, or the small intestine. So we're either going to take a pill through the mouth, we're taking it up, or a liquid through the mouth, we're taking it through the mouth. It has to go through the GI tract. Because if we're talking about a gastric mucosa or small intestine or the mouth, that's the GI tract. So that's why you see it's oral, sublingual, anything up under the tongue, because we're in the oral part, right? That's the mouth. Buccal, if we pull the cheek back and put that medicine, that's buccal. Or rectal can also be, but also can be a topical. So it just depends on what we're doing rectally. But just so you know, if we get up in that gastric mucosa, it can be considered an enteral route. So just know that. That's what enteral is. And you will need to know enteral and not just, I'm just giving it by mouth. Yeah, we need it to be enteral. So parenteral is where we give either IV or we're going to give it in an injectable. So we have intravenous, which once again you see right there, it's the fastest delivery into the blood circulation. So if you ever see that, it's the fastest. If you have to pick the fastest way to give a drug, you're going to give it IV. Now, not all drugs can be given IV, but you'd be amazed what's out there. There's actually IV, this, that, and the other. I didn't even know existed because I never gave it to adults, but we do a lot of IV stuff with kids. And as time progresses, things morph and we get better at making our drugs. Intramuscular, subcutaneous, intradermal, intraarterial, we're giving it an artery, Intrathecal or intra-articular. So these are all parental routes. So it's a good thing to understand that. Now, topical routes or routes are the skin. We include our transdermal patches. I do want to say this about a patch. If you are putting a medicine patch on anyone, if it's a pain patch, if it's a nitro patch, if it's a nicotine patch, whatever the patch is that you're putting on your patient, if it's one for motion sickness, anything like that, you need to always look to see if where the other patch is. If there is a patch on them, please remove that patch. Wear gloves because you can actually get the medicine on you. You want to remove the old patch, clean that area gently by patting dry, and then you're going to apply a patch somewhere else. Never put a patch over the same patch, because what happens is you're going to irritate the skin and have skin breakdown, and we don't want that. So remember, go back for my students, review your transdermal patches and how to apply. Eyes go under topical, ears go under topical, nose, lungs with inhalation if we're doing inhalers. And then the rectum, which I know was on the other, but it can be topical depending on what we're doing. But if we get on up in there, we'll be into the mucosa. And if that's the case, it's not considered topical. But if we're down with hemorrhoidal stuff, then we're looking at the rectum. It can be topical. And the vagina. So for time and for you, I have a few slides. It's repeat, it's back information, but once again, presenting it to you of the pharmacotherapeutics, all of that. Read through those, they're for you. I've already explained them, but I just passed on through. I don't need to lecture that again. But let's get to this slide because this is an important one. Adverse drug event. So when we have that, it's a life-threatening reaction that requires medical intervention to prevent death or permanent disability or congenital anomalies. So this is an adverse drug event. This is big time. This has to, with exclamation points, be reported to the FDA. What happens is the FDA will take that information, they will start to look at it, they can actually maybe change ratings, give it a black box if it's causing problems so that people know not to use the medication. The FDA can take it off the market if needed. We've had drugs that have been on for a long time and now they're off because we've had so many different issues over time. Some it takes longer to pull them off. Some it's very quick. They realize this is not going to work and they have to pull it off the market. A black box warning is something you need to know. It is issued on medications that may produce lethal results. So they'll get a black box warning if they have any, can cause adverse drug events. So if the drug is still on the market, you might see a black box warning, and that's just letting you know. So if it can cause congenital anomalies, we're not going to give it to pregnant women because we know that we can cause this to happen. One of the drugs, and I'm sorry because the brain's just trying to get it together, but there was a drug that we gave back in the 60s, late 50s, early 60s. It's Philippa something. I can't think of it right off my tongue, but it was a drug that we gave pregnant moms for morning sickness because it really worked. It was like a miracle drug, but what we found out is it crossed over, causing these children to develop almost like a partial arm, a flipper-like arm or legs. They could be all four, just one, two, whatever, but they started to see these babies be born this way and realized the drug was causing it. It didn't get a black box warning. It got ripped. But let's say we have a medication that's great for someone who's not pregnant. It's not going to do that, but would cause that congenital anomaly. Then we want a black box warning. It can cause death if we're not careful. These are drugs that we need to watch, be very careful. So if you see it, you need to put it on your drug card. Know it's something to be aware of. Allergic reactions, my gosh, we have allergies. I never had allergies, and now I have allergies to pollen and mold and stuff like that now. So I'm sniffly as the seasons change. It's always like you know how it goes. But a drug sensitivity or a drug allergy is something else. And when you look at it, same thing happens in the body, and we'll study that further when we get into allergic reactions, where we need to have medicines to stop the histamine process, you know, that whole cycle. So allergic or hypersensitivity reaction develops when the body perceives a foreign substance. And for this case, we're looking at medications. What it does is it triggers the histamine response in the body, and we start to have all of these things go on, right? And if we don't fix it, it can get bad. But the adverse reaction produced histamines. That's why we give antihistamines for allergic reactions. There are drug allergies, and there are other things that people can have or be allergic to. Bee stings, and that's why I put that cute little bee, even though I love bees. But people that are stung with wasps, things like that, they can actually have really poor outcomes. Peanut butter, it's a biggie. We're finding gluten to be a big issue. People are very hypersensitive to gluten, but we're talking about drugs with this. So we're looking at allergic reactions to drugs. So with drugs, if we have an allergic reaction, excuse me, I am just belchy. I had some lunch just a minute ago, and it's actually dark out, so it's dinner time. Anyway, if we are taking medications and we have an allergic reaction, the thing that we need to worry about is if this reaction continues, if that histamine response, if things just keep going, we're going to go into anaphylaxis. And anaphylaxis is a severe life-threatening reaction resulting from a histamine release, producing dyspnea, which is difficulty in breathing, hypotension, blood pressure is going to bottom, and tachycardia, which is high pulse rate or high heart rate. So we're going to beat faster, blood pressure is going to bottom out, and we're not going to be able to breathe. Throat will close up, and we will lose airway and can die. So this is something that is life-threatening. This is something that we need to be on top of. So when somebody has an allergic reaction to a drug medication, it's not something to take lightly. Even if they just have hives. The thing that really rings true to me is back when I was in EMT school, 100 years ago, I was in an EMT school, and I'll never forget the paramedic that was teaching us. He said to us, the thing I want you to know about stuff out there is we are allergic to just about everything. And in time, some people will show that allergy, they'll have an allergic reaction, and some won't. But when you have that allergic reaction, that first time you get welts or whatever, just know each time you're exposed to that allergen, you will have probably a worse outcome. Saying that, I'm saying this. If you have a patient that says, oh, I just get a little itchy and red when I take this antibiotic, it's not something to take lightly. You need to make note that it's an allergy. Call the physician. Sometimes what they can do is give the medicine anyway, but prep the body by giving, you know, an antihistamine, trying to prevent some of the allergic reaction. But if they might say, no, we're not giving it. Or let's just say they had hives before, forget to tell you, and then all of a sudden they hive all the way up. You need to be concerned. If they keep going, if that histamine reaction keeps going and it's exorbitant, they're going to go into anaphylaxis and can die. So it's very, very important. Know what anaphylaxis is. Now, my students aren't going to be tested on this next test, so don't get freaked out. But I want you to hear this for the first time because you're going to hear it, you're going to see it, and we're going to talk about it more down the road. Oral medicines pass from the small intestine to the hepatic circulation via the mesenteric vein and a portal vein flowing into the liver. That's anatomy. Just kind of, you know, read through that. But while it's doing that, oral medicines pass. If you give a medicine for the first time ever, this is the first pass effect. It'll result in a lower concentration of the medication in the systemic circulation. The reason why that first pass effect is so important to kind of understand is when you're looking at a MAR or medicines, you might have a medicine that the doctor will order and he'll give this amount. Then you get a second dose and it's less, and you're wondering why. Well, it has to do with that first pass effect, because the first pass effect will have a lower concentration of the medicine in the systemic circulation. So we need to understand that. So just kind of make a little note in your notes. First pass effect, And we'll go further into it, but just know you've heard it for the first time, and it's something that is real. And we can sometimes bypass going that route with medicines and give it a different way, and the patient then can get a full dose. Just FYI. So how do we get rid of meds? The body. We excrete the process of drugs from the body. The kidneys are the primary organ responsible for drug excretion. So what do? We metabolize, we process, we pull this, we pull that. It gets down to the filter of the kidney, and the kidney's like, hey, it's time to get rid of this mess. We're getting rid of all the toxins of the body. It'll pull it, and you'll pee it out, right? Great. The skin, lungs, exocrine glands, intestines excrete medications at a lesser extent. They still do excrete the meds, but the biggies are the kidneys. Drug toxicity develops when the body's unable to metabolize and excrete a drug. I do want you to understand that and know that. If the body can't metabolize or excrete the drug, they're going to become toxic. Now, you might not see it on a test question this round, but every time we look at any disease process, any patient we're looking at as we move forward, if they've got a problem with metabolizing and excreting, and we just said it's the kidney, the liver on the other piece, skin, lungs, that kind of thing. If we have any kind of issues or problems and they're unable to metabolize it and excrete it, we're going to probably have drug toxicity. So we need to understand that. Ding, 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 understand that. Don't think you'll see it this round, but you will see it soon. So teratogenesis, some medication are categorized as teratogenic or known to cause fetal defects. These are birth defects. So like I was talking about that one medicine, I will come up with it tonight at 2 a.m. I'm going to be like, whoa, that's it. I'll say it probably out in my sleep. But they'll get a black box warning, or they'll be removed off of it if they're considered that. And that's why the big black box is there, just to give you a little black box. Now this everybody needs to know. Medication orders. A complete medication order should contain the following information. It should have the client's name, of course, because what are our rights? This goes back to those 6 rights, right? We're seeing them plus, but client's name, so it's right patient. Date, time the order was written, always. There should be a date. So we know that's a start date of when that order was given. And then, of course, if they discontinue that order, we'll know that it went for this many days, whatever. We always need a date and a time. Very important. Drug name, generic. Dosage, how much are we going to give? We're back to those 6 rights, right dose. Route of administration, we always in the order need to have. Is it a PO? Is it an IM? Is it an IV? Do we need to get sublingual? Is it going to be given rectally? Are we giving it topically, you know, as a patch on the skin, whatever? Apply cream to the back of the arm, the irritated area in the skin. We need to be specific of the route that we're giving. If you just have a drug out there, 20 milligrams of Lasix to be given twice a day, and it doesn't say PO or IV, you need to have clarification. You will call the physician at the time to get clarification of your actual route. So all you do is call up the doctor, say, hey, for me it'd be, hey, this is Kristen, I'm Miss So-and-so's nurse. I see you have an order for Lasix 20 milligrams, but I'm not sure how you want me to give it. I just need clarification of your order. And he'll say, I want you to give 20 milligrams Lasix or furosemide, IV, twice a day, starting now. And you'll just go ahead and you can ask them to put it in the computer system if that is the system you work under, but you can take a telephone order, a verbal order, or a telephone order. It'd be on the phone if I'm calling. And it's always read back. So it's telephone order read back, and I'm going to immediately say, okay, Dr. Jones, I want to read this back to you. You want me to give furosemide Lasix 20 milligrams PO, BID, or twice daily, starting now. And he can say yes, no, whatever. If he goes, yes, that's correct, then you're good to go. But always read back so to make sure you heard and understood what they say. It's so, so important, guys. There are so many times that I have read back and the doctor said, ooh, wait a minute, no, I want this, and he will tell me something different. So it's a good way to catch errors, and it's also a good way to have someone else think about what what's doing. And I'll tell you, after a doctor gets called a couple times, they won't make that mistake anymore. They'll put the route in. Frequency, twice a day, once a day, every other day, every 4 days. Remember to look at your abbreviations because you do not want to use the ones that are not used anymore. We used to have QID, QOD, QD. So we're starting to spell those things out. Indication for use needs to be there, and then the provider's signature. Never give anything without a doctor's order, and the doctor's order is correctly written if it has all of these components. If one component isn't there, it is not a complete order, and you need to call for clarification, or if they're rounding, ask for clarification, have them put it in the system if that is the system you work in. If not, they can rewrite it if they're there, and if it's not that, then you can take it as a telephone order, and if you do, always read back. If you receive a verbal order, doctor's standing there saying, no, I want you to give this, and he gives you an order, always say the order back. It's a read back, verbal order, read back. Always do that. My nose is itching, excuse me. Always do that because that's what's going to protect you. So once again, for routes, I want to go over them. Enteral, it's administered directly into the GI tract. Remember, mouth, buccal, sublingual, we're in the mouth. Anything oral, going down those tubes into the stomach, going through the GI tract all the way down. Rectally, if it can get up to that mucosa area, it's considered enteral. If it's on the outer part or whatever rectally, it's topical. Topical is applied directly to the skin, mucous membranes of the eyes, nose, respiratory tract, vagina, rectum, and urinary tract. And the urinary tract stuff, it's a topical. We're putting it on. We'll talk about it. Parenteral is administration by injection using a needle or syringe or a catheter. So it can either be an injection into the body or we're going to give it IV because parenteral is also IV. Just remember that. Fastest route, IV. So last slide, guys, high alert medications. You need to get it. High alert medications are drugs that are associated with increased risk of causing considerable client harm when they are administered in error. These are drugs that cause no harm if given correctly, but if you give it incorrectly, if you give the wrong dose, the wrong time, if you're giving it in the wrong route or anything like that, it can cause harm to your patient. That is considered a high alert medicine. We can cause harm. Insulin, opioids, narcotics, IV heparin, injectable potassiums are all high alert medicines. You inject potassium through an IV, that is the biggest no, 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 no. You do it, you're going to kill your patient. That's how we actually euthanize people, is by giving potassium and some other things. But what it does is cause cardiac arrest. So we never want to do that. You give too much insulin, you can kill it. I had a nurse tell me this story, and I want to share it with you because it's a good one. She actually shared it with me just this past year, but she was working with a nurse, and it's been a couple years back. And she was a nurse that came in and wanted to get everything done, right? Fast, get those medicines out. She'd pull all her meds, everything, not doing it safely, not making sure because she didn't want to waste her time. She was trying to be really good with her time, on it. So she was one that did it incorrectly, where she went and would get everyone's meds in baggies, put their label on and all that. And so she was pulling out this and pulling out that, and she went and she gave all her meds. And she got to this last patient, and she was going to give this patient insulin. And let's go back to the checking 3 times with your MAR and all for safety. This is why 6 rights is so important. So she had another vial. It looked the same. And yeah, it was insulin, I'm pretty sure. So she had a vial, and it looked the same. It looked very similar. And so what she did is she drew up the entire vial. No, it wasn't insulin. I apologize. Let me go back. It was 2 drugs, but what it was is one was Lasix, and the whole vial would have been given for Lasix. And the other one was where you gave just like a 0.5 milliliter. And I want to say it was like an opioid of some form. And what happened is she gave the opioid to the person who was to get Lasix. She drew the entire amount up, gave it, and then when it came time to go give the opioid, she pulled out and she had a vial of Lasix in her hand that had not been touched. So so when you're pulling meds and she wanted the nurse to check off on the opioid. She wanted it to be the second signature. And this nurse that told me the story said, I just said, well, let me see your vial. And when she pulled it out, I said, she goes, that's Lasix. And that's when that was like that. And she knew how to send the patient to ICU. The patient ended up being fine, but had to be put on monitor, be watched, all this stuff. It was a big to do. So it's something definitely. High alert medicines takes 2 nurses verifying the identical information. So don't ask anybody, not even your best friend. If you don't see them draw it and they show you the syringe and show you the medicine, you don't sign off on it. Make sure you know what the person's giving, because you're signing your license off that they're giving the correct medications. So high alert medicines, good to know. This hopefully will help you as you become a safe practicing medicating nurse, giving medications, administering to patients and clients. And so I hope it helps.